Mari McInerney from Croaky here, and I'm talking to Lesley Salem at the APNA Nurses Conference in Brisbane. You've just given an amazing keynote, Lesley, sorry, but can you just introduce who you are and where you're from culturally and in terms of your work now?
My name is Lesley Salem. I'm a Gidgee Wanneroo woman from New South Wales. I now work at the moment, I've worked through many AMSs, but at the moment I'm up with Gidgee Healing in Doomadgee in the lower Gulf of far north Queensland.
Thank you very much. Now, can you describe the community a little bit and what the health service is there? I gather it's pretty much nursing led.
No, it's at the moment, we've been charged with starting a primary health service within Doomadgee. So it's mainly been a very small hospital there that treats acute patients, but there's so many health issues and life expectancy is poor that they now want a primary health service. So it's meant to be a doctor and nurse and health worker led clinic, but it's difficult to recruit people up into very, very remote areas of Australia. So quite often, as a nurse practitioner, I'm the one taking a lead at the moment.
And can you just actually say where it is, how remote you are?
So Doomadgee is probably 100 kilometres down from the Gulf of Carpentaria and about 130 k's in from the Northern Territory border.
Fantastic, thanks. Now, and also just to position you, you said it took you a while to come over from the dark side of doing acute nursing. What brought you over?
It was several things. One, we know that chronic kidney disease can be put into remission and regression at an early stage. Heart failure can be prevented if you treat blood pressure early in a lot of cases. So many things can be prevented, and I think I was very saddened and tired of working downstream of chronic disease and always with people with end-stage renal failure, end-stage complex diabetes with complications, heart failure, and so I looked upon that as being at a stage where you could just band-aid all the symptoms, and I wanted to work upstream to do prevention. So with pressure from my dad, who was a Wanneroo elder, and community where I live, I was being made to look more at moving out into primary health, and so the dark side for me was working in a tertiary referral unit with end-stage disease, and then I feel like I've come into the light now working in primary health.
Fantastic. Now, but you talked a lot about health promotion, and you talked about big issues with bad ways of trying to do it, particularly for Aboriginal communities, also for other disadvantaged, vulnerable communities. What do we do wrong?
I think sometimes when it's a top-down approach, you don't realise the social justice implications of what you're doing, or the stigma that may be attached to flood an area with discussions about STIs or heart disease or other things. Sometimes the community takes that on, that everybody thinks that they're dirty people, or that no one's well, or so there's a stigma attached sometimes. And so sometimes health promotion through means that the patient, it's in their face everywhere, the community, it can have negative effects. So it's really great when you're attached to social media, but and you can choose what you read, but some health promotion strategies leave patients feeling that the whole community is viewed with that view.
You talked about very unsafe cultural practice too in the health system, of specialists flying in and not being aware of anything. Can you give some examples of that stuff that really does harm?
So sometimes we get visiting specialists, and not all, but we get a lot of them waltz in, and they'll have a registrar and a trainee, and the patient is asked, with all of them present, do they mind if they're there? And the patient is already anticipating that they're fearful of what's going to be said. They don't say no, but they're very intimidated, and it's a very paternalistic way that the patients are dealt with. And so the messages that those people are trying to say will get lost because they're not listening. They're not hearing the language they're speaking. A lot of people speak Aboriginal English, and they don't understand the complex way people start to speak to them or talk about the tablets and using the very big names of the tablets. Or and another issue is a lot of messages And health promotion is very hyperbolic. So it's always, if you don't take this, you will get this. If you don't do this, you will lose your leg. If you don't do this, this will happen. And for a lot of people, especially a lot of us in Aboriginal communities, live in our past and the present. And so if messages are very hyperbolic, driven to the future, people are not thinking about that. And so messages need to be driven to the now and the and what they can think and feel now. So messages need to be very careful the way they're structured and to what group they're being given to. And if a lot of people are speaking Aboriginal English, the health promotion isn't coming out in that. Not always. Some is, but not always.
You talked about health-seeking behaviours and how you're seeing some impact with kids, but also around how what you're trying to do is, talk to mums, talk to schools. What sort of things, what can you suggest are really good practices with that?
Involving everyone in the community who can help. So if you want to tackle scabies and there's not many washing machines in an area, getting groups that are possibly able to have industrial machines so that people can take their washing to be done at somewhere like Save the Children or wellbeing centres or PCYCs. So having other groups that can possibly makes the environmental changes, so tackling scabies where you can provide the treatment and the advice, but then getting others involved to help with soap making, tea tree oil or Yarrabah bush soap making, and encouraging regular showering with traditional medicine soaps and having a place where washing can be done. So the change from ground up health promotion, I think it always involves everyone in the community working together on a strategy and who can do what, so you can tackle that issue.
Now, you promised you'd get NARCI, and is it about government? You talked a lot about funding for practice nurses or lack thereof, and just whole approaches like that.
I'm a nurse practitioner, and I can diagnose you with diabetes, I can diagnose you with heart failure, with chronic kidney disease. I can initiate all of your treatments, educate you on it. I do my own treatment plan. I'll do a whole health assessment, and yet I can't claim a 715, a health assessment, or a GP management plan. All the work I do is invisible. And yet I'm diagnosing and treating these patients, and yet I can't understand in this day and age why I'd be given 4 timed item numbers and not have numbers that reflect the work we're doing, so that you can see the usefulness of nurse practitioners in Australia. You wouldn't know on a 20-minute timed item whether I did a wound dressing on someone, sutured a traumatic cut, or gave immunisation. So, and this goes along with all the practice nurses. There are many item numbers. You wouldn't know if they were giving an iron infusion, doing the suturing for the doctor to claim, or talking to patients. It's ridiculous in this day and age that we can't be attached to item numbers that reflect and remunerate us so that we're employable, through Medicare.
So who needs to get on board?
I know there's one study underway with nurse practitioners, but the MBS review, I know nurse practitioners are in the last tranche, and I think at this rate I'll be retired before I ever get to see that tranche go through. And MBS item numbers for nurse practitioners absolutely reviewed. It's very hard to make a living when the most you can pull in is about $100 an hour before tax and everything, and then you've got to pay so much to rent a space or give it back. So you can't possibly go into practice yourself and then you give it all back to the practice. It's very low wages, very low.
Your message to Greg Hunt, and I know you email him.
Please read my email, but please have a really close look at the work we're doing as nurse practitioners. Look at our item numbers and please make them appropriate for the work we're doing. Out where I am, I'll do all the scripts, all the suturing, skin biopsies, diagnosing chronic diseases and treating them. Surely that's worth being remunerated for the job that we're doing.
Now, on a slightly good note on the MBS review, there has been they've added the for renal.
There's a
You
new
tell
renal item
me.
number now
Yes.
to have dialysis for Aboriginal people on country. So have a look at that one, and that's been a great win for Aboriginal people. Very great win.
What
Very
would
proud.
that mean for your area?
It means people don't have to be off country if the item number will cover costs and things to get a person back on country. So that'll be really great.
So we'd like to see a bit more of that then.
That'd be good. That'd be really
Fantastic.
good.